Schmölzer. So we welcome all the participants for this Learn from the Legend series. I think without wasting much time, we can ask the professor to share his screen and start the proceedings. Sir, you can share your screen, sir.
Yep, I'm on it. Thank you, everyone. Thanks for inviting me, and
your screen is
hello
well
to
seen,
everyone.
sir.
Thank you.
Your voice is clear.
Good, thank you. So thank you for inviting me today to speak about an area which I have spent the last 10 years or so doing a lot of studies to figure out how can we improve the approach to chest compression if babies actually need that. And it's also good timing because not only we've completed the trial a year ago trying to find an answer, and we also in the process of planning the next study. We tried a large study, we weren't as successful as we were hoping, so we are trying to organize another study and recruiting interested sites to join us when we would start working on the next trial, which was initially called Survive. I just want to disclose all the funding I received for all the work around chest compression, and the technique we discussed today is something we developed in our lab with my colleague, Professor John. I'm pretty sure everybody on the call knows that most babies don't need our help, which is great. 10 to 20%, depending on the paper you're reading, they will need the respiratory support, which is the most important intervention we have to support the newborn baby. Unfortunately, there is occasions, and they're certainly rare in term babies, but more common in preterm babies, where these babies would require chest compression, as well as medication, and in that case, it's epinephrine in the delivery room. And that's around 2 to 3 million a year. There's still up to 1 million babies who die annually, and many of them might have received chest compression, but there's also many who did not receive chest compression for various reasons. If you receive chest compressions, we face the problem that they have high incidence of mortality, as well as short and long-term neurological morbidities. And certainly when you have to do CPR for more than 10 minutes and there's no signs of life, you are faced, in particular the parents are faced then with high mortality, and in the survivors, moderate to severe disability is high. So that certainly always begs the question, as you have such a poor prognosis associated with CPR, is there anything what we can do to improve it? Are there techniques out there which are then specifically tailored to the newborn that it could improve outcomes? What's our problem? Well, certainly we don't know when a newborn needs CPR. They are infrequent. In our hospital, which is a high-risk delivery level 3 hospital, we might do 10 CPR events in a year. So it's rather rare for many hospitals. There's other hospitals where they are more common, but in many, it might be rare. So this is certainly something which prevented us to perform rigorous clinical studies. So most of the data we have comes from either animals or pediatric, as well as potentially mannequins and or animal models. Now, these are the latest guidelines from 2020, which summarizes what we should do for chest compression. Within the next few weeks, there is the 2023 consensus statement will be published. Within this consensus statement, there will be a scoping review about chest compression, but unfortunately, since the 2020 guidelines have been published, there hasn't been much human data, so there will be no real change to what is on that slide today. This paper from Anders Sollerud gives you a really nice overview of what factors influence the efficacy of chest compression. So there's a lot of different factors, and then we'll talk about a few at the beginning, and then mainly focusing on balancing chest compression and ventilation to look at the chest compression to ventilation ratio. Now, chest compression depth. The guidelines tell us 1/3 of the anterior posterior diameter. Studies using MRIs and CT scans also tell us, look, if you squeeze the chest by 1/3 of the AP diameter, you get the highest ejection fraction, and it does not result in too much over or under compression. Now, an animal study which developed a plunger, like you know from adult resuscitation, specifically designed for that animal model in newborns, in piglets, was investigating that, and certainly found that if you do 12.5%, so a relatively small depth, you will not have enough cardiac output. So all these piglets died. But once you start getting into a depth of at least 25%, you don't see much difference. It seems that you need to get over a threshold and not necessarily have to target a 33% depth, which I always find challenging because we have no feedback mechanism, like in adults or pediatrics where they have feedback mechanism, how deep they are pushing. We don't have that. That's something which is missing. And if someone develops that, that would be really great. So it's really hard to teach it, but I think if we can figure out ways to teach that they have to push to at least to this depth, then we might see an improvement in outcome. Similar for chest compression rates. Now, the guidelines tell us we should use a rate of 90 chest compressions per minute because we do 30 inflations as well. So you end up with not more than 90 chest compressions. Now, in these studies, again, with this plunger, because otherwise it's rather challenging to achieve a rate of 180, they found that it wasn't significant because I guess the numbers of piglets they used wasn't large enough. But overall, it seems that with the higher rate, there was a shorter time to ROSC, which was only 0.08, and more of those piglets achieved ROSC. And why were they using a higher rate? Well, this was based on a mathematical model, which was published more than 10 years ago by Babs, who said that the rate of chest compression you need will be proportional to the weight of the patient. And in a newborn baby, it's around 180. Now, when you look at comparisons of different rates, like trying to resuscitate with 60, 90, 120, 150, and 180, it appears potentially that the rate of 150 might be even better than 180, because as you can see there, by looking into stroke volume, left ventricular function, there seem to be plateauing around 150 chest compressions per minute. The cardiac output, and this was the mathematical model based on by Babs et al., just looked at cardiac output. And if you have the same stroke volume, but you have a rate of 150 and the rate of 180, your cardiac output at rate of 180 would be much higher because it's just a mathematical model. So maybe we need a higher rate, but I think there needs to be further studies before this would be something we could consider. Now, the correct technique is also something we should potentially pay a little bit more attention to, and this is from a scoping review, which was published this year in Archives by Ramachandran. And what you can see is that there's many different techniques out there which have all been tested in mannequins, and hasn't been any other studies really than mannequin studies to assess what is the best option. Now, certainly within mannequin studies, we might be able to test fatigue, but otherwise to look at cardiac output or other factors, it is quite limiting. So this study by Bruckner et al. we're comparing 4 of these 8 techniques you saw in the screen before, and found that certainly the two-sum, either from below or over the head two-sum, seems to be with improved stroke volume, certainly compared to the two-finger technique, as well as the left ventricular function seems to be improved with the two-sums technique. So while ILCUS and the guidelines, as well as the treatment recommendations, say two-sums over 2 fingers, it might be that whenever possible, we should use the two-sum technique and not use the two-finger technique at all, because it seems that your stroke volume is lower when you use the two-finger technique. Now, before I move on to talk about the CV ratio, the last point is the oxygen concentration. Now, we use 100% oxygen because this is the amount of oxygen the guidelines are recommending. Now, there hasn't been any human studies. There has been 7 animal studies from also all summarized in this scoping review, and they all showed that there is no difference between 21 and 100% in mortality or time to ROSC. Now, is this something which needs to be studied? Yes, because we might not need 100%, or maybe we need 100%, but this is unclear. This is certainly also something I was trying to start a trial on, but when you talk to or ask other colleagues, there was a reluctance or fear to start AIR, and so many would have said, I'm happy to do 50%, which might be a good starting point or a middle point, but certainly not AIR. So certainly there's more work to be done, but if anyone on the call works in a hospital where they don't use 100% or don't have 100%, this data would be really welcomed if they are published by ILCUS, because it would just give us a little bit more feed for thought about this topic. Now, the one area I really want to focus the remaining time is the current approach with using this compression to ventilation ratio and the things we have done in our lab over the last 10 years. Now, we use 3-to-1 because we have a higher heart rate, a higher breathing rate, and hypoxia is our most important factor for our cardiac arrest. So we need to figure out ways to combine ventilation and breathing, chest compression and ventilation, to improve oxygenation, so that then hopefully the baby can have ROSC. So ventilation is more beneficial. However, what's the optimal approach? We don't know. Now, there has been many animal studies where they were doing different approaches like 2-to-1 or 4-to-1, 9-to-3, 15-to-2, and they all did not show any difference. And the question is why? And I think one thing which is often overlooked is a really simple thing which might explain why any of these approaches did not really improve outcomes. And this is a really nice study by some anesthetists in our university. And what they actually wanted to do is they submitted an application to the Neonatal Research Committee, and they were saying, hey, can we just gently push the chest of your preterm babies and to see how much gas will come out? And we were like, no, we don't really want that you push our baby's chest, whatever gently you would like, because we would be worried because there would be like 25, 26, 27-week preterm infants. So we refused to study. They went on and did the study then in children from 0 to 18 years when they had to go into the operating theater. And what is quite interesting is so they gently push the chest, really gently, And I will just zoom in into the less than 1 year old. And what you can see is even by just gently pushing the chest, you move a lot of tidal volume. So actually, when you gently push the chest, you might push out more than the dead space, 4 or 5 mils per kilo. So now when you do chest compression where you push much harder, you might get even more tidal volume moved. So it seems that there can the lung can de-recruit doing chest compression, which might be an explanation why these 2-to-1, 4-to-1, 9-to-3, 15-to-2 approaches did not work. So when we investigated that in our lab, and you look at 3-to-1, what you can see is you can see there's big inflation, which is classic, where you do 1 and 2 and 3 and breathe, you see this inflation, and then you see some further chest compressions here, which will move some air. And if you analyze each of these respiratory waveforms, what you can see is that you get a big inflation. When you push the chest, you get a big exhalation. Then you get a little bit of inflation again with the chest recoil, but more air is pushed out with the next chest compression. A little bit of air comes back in and more air gets pushed out. So over time, with each of these cycles, you can lose up to 4.5 mils per kilo. So if you could do this for a long period of time, you might not be able to recruit the lung, and you're potentially just de-recruiting the lung as you go on, and which might delay the time to ROSC. That's potentially the reason why these studies did not work. Similar, when you would do continuous chest compression and then asynchronized ventilation, like you know from PALS, again, you can see with each chest compression, there's gas moving in and out. And that could also result in up to 6 milliliter loss per cycle. So again, if you use this approach, you might again not improve your time to ROSC or your outcomes. And again, this has been shown in piglet models as well as in lamb models, where there is no difference in time to ROSC, and this might be one of the explanations. Now, we went a different way, where in 2012, when we did the study, we used 3-to-1, and then we did a second group. In the second group, what we did is we used continuous chest compression. So you don't stop, and you use a high descending pressure, which we call the sustained inflation, because if you go back 10 years or 15 years, sustained inflation was a hot topic in neonatology, and everybody wanted to do studies and figure out if sustained inflation as the initial respiratory support would improve outcomes. So we did the same. We called it sustained inflation, give the high descending pressure of 25 to 30 centimeters of waters, and just provided positive pressure ventilation. And these were, in our initial study, the results, where you can see 75% faster time to ROSC, significant higher survival. And what's the difference? You just occlude the T-piece and then provide continuous positive pressure ventilation. Again, you see air goes in and out of the chest, but the difference is when you squeeze the chest, the air comes out, and when you release the chest, because you give that high pressure, a lot of gas comes in. In the end, you can get up to 2.3 mils per kilo for each of these cycles. And this is like 8 up to 10 of these chest compressions, which then over time will improve your functional residual capacity and your lung volume. So you're actually gaining lung volume, which is what you need to provide better oxygenation. The second thing what this technique does is that for chest compression in general, you have this cardiac pump theory, because you squeeze the heart between the sternum and the spine, and this ejects the blood. But also, chest compression can increase intrathoracic pressure. So if you provide continuous chest compression, you get an increase in intrathoracic pressure, which helps to flow the blood. Sustained inflation does the same. So then you actually have two mechanisms which increases the intrathoracic pressure. And if you look at comparing 3-to-1 with the other approach of this continuous chest compression with this asynchronized ventilation, you can see that pulmonary artery flow, carotid artery flow, so that the blood flows within the body is not really different. But when you look at CCSI, as we called it, you can see that there is a significant improvement in pulmonary artery flow as well as carotid artery flow. Your pressures are also improved, pulmonary artery pressure or mean arterial pressure. A lot of people then are always concerned about, but it will affect venous return. The CVP was not different to 3-1. So that certainly shows that this approach, this technique does not interfere with your venous return, which is important to achieve time to ROSC faster. And after many years of doing many of these studies, where we found always the same results and never find any concerns with lung or brain injury, not by just inspecting the piglets, nor by doing a lot of injury marker testing, we went on to do studies in newborns. I wanted to point out that there are a couple of studies out in a lamb model who investigated CCSI as well. They found no difference. However, I think the main problem is that the model isn't perfect to study that technique just because of the differences I just explained. And one of the problems with the sheep model is that you have to come from below the sternum or sometimes from the side of the chest and do chest compression, which is not might not work. So the mechanism might not work as what we believe CCSI does. Now, as I said, we moved on to the newborn infants, and in newborn infants, initially we included less than 32 weeks gestation because we would have been there all the time for other studies. Sorry, or just because we would have been present because there was our hospital policy. And we did a really small pilot trial of 5 with CCSI and 4 with 3-1 and found basically the same result. Much faster time to ROSC with CCSI compared to 3-1. Now people can argue, well, if it's only 31 seconds, you should have never done chest compression. And I agree, but normally this was a clinical decision and not made by the research team. So they might have just started because they thought, oh, the baby needs chest compression. All of these babies would have been intubated before they would have received chest compression. So they would have gone through all the steps of Mr. Soper, and no one would have jumped straight away to doing chest compression. Also, in line with what we saw with the animal studies, that the minute ventilation was significantly higher, which might have helped to speed up that time to ROSC. And once we had all this, we started to apply for grants, and we thought it's time to do a multi-center cluster randomized controlled trial. And we did cluster because we are fully aware how stressful and challenging it is to do a chest compression study, and having an envelope or maybe a computer randomization when you know you need to do chest compression would have been impossible, and most likely would have missed most of these babies. We had a steering committee as well as a statistician who was part of the data safety monitoring committee. And I think we had a really experienced data safety monitoring committee with Neil Feiner and Myra Wyckoff, who was the chair of ILCOR, the neonatal task force of ILCOR at that time. The primary objective was to see if sustained inflation will improve short and long-term outcomes in any newborn baby, preterm and term, who requires chest compression. The primary hypothesis was that it will decrease the time to ROSC, and the primary outcome of time to ROSC was chosen by the DSMB because they weren't sure about if we should use mortality, because it's the first trial ever who would examine chest compression. So time to ROSC was our primary outcome. We went back the last 2 years to assess how many babies we had with chest compression, how long was the duration of chest compression. So we then had a certain duration, and we thought, okay, well, if we can reduce this by 33%, if it's like 9 minutes and we can reduce it by 33% to 6 minutes, that would be clinically significant. And in the end, we would have needed 109 babies in each group if you adjust for the cluster randomization, so 218 infants in total. We include all preterm and term babies in the delivery room, and if there were congenital abnormalities, like a congenital diaphragmatic hernia, for example, or congenital heart disease, this would have been excluded, as well as if parents would have refused to give consent. As I said, we added cluster randomized, and each hospital was randomized for a total of 12 months to one group, and then there would have been a 2 months washout period to train the hospital to the other intervention, and then they would have flipped to 3-to-1. Now, in 3-to-1, you would do what you would normally have done according to your guidelines. You do 30 ventilations, 90 chest compressions, reevaluate your heart rate every 60 seconds. With CCSI, you would do continuous chest compression at 90. You would deliver the sustained inflation, as you saw in the video, while you're doing chest compression for 20 seconds. Then you stop, just do PEEP, so you get your finger off the T-PEEP for 1 second, and then you do another sustained inflation for 20 seconds, and you continue chest compression. And you repeat that. And then after 3 of these sustained inflation, you basically have a minute, and you do heart rate assessment. And you continue that as you continue chest compression. Now, the DSMB put in an opt-out rule or a stopping rule. If you do more than 5 minutes of CPR, if you're doing CCSI, you had to convert to 3-to-1. The time to ROSC was defined as a heart rate more than 60, which you had to sustain for 60 seconds. And if the heart rate would just drop up to 65, you stop CPR, and 20 seconds later, it's back less than 60, and you would restart CPR. This was not yet time to ROSC, so they would have not counted. And with a lot of secondary outcomes to assess, particularly safety of the intervention. Now, this is a map, and none of the flags presents a particular city. This was just sites who were interested in participating. And we started the trial, but shortly after we started the trial, the SAIL trial was published, which showed that if you do a sustained inflation in 23 to 26 week gestation infants who require initial respiratory support, there is a higher mortality. So with knowing that, and we including all preterm and term infants, we stopped the trial, we discussed it with the DSMB and said, okay, everything above 28 and 0 can be included. So we restarted the trial. But at that time, a lot of sites lost interest or were afraid because of the SAIL trial. So we certainly had a problem that a lot of sites dropped out. Then also something which was challenging and I've never seen before, that several of the ethics boards didn't want to approve the study and said, no, it's too dangerous. I want to wait for the first interim analysis to see if it's safe, which I don't think you would see for a pediatric or an adult study that they would say that. So certainly something I've never came across and was quite problematic. Similar, insurance companies were, because you need trial insurance. So in the case there were any deficiencies in your protocol, did not want to insure the trial. So having a study where you have newborns receiving chest compression, it was extremely challenging to get sites on board. But in the end, we managed it. Sites were ready to start. And you can see as this was taking on quite a long time, more and more sites dropped. But then we had several sites to start, and then unfortunately COVID came around, so we had to stop again for the initial period because we weren't allowed to do any research studies, mainly on starting new studies. And in the end, unfortunately, we only left with like 4 sites who were recruiting, 2 in Canada and 2 in Europe. And instead of having 109 infants in each group, we only ended up with 11 and 14. And we had to stop the study, not because we wanted to, but after working more than 5 years on it, we couldn't renew the grants, so the funding was ending. So we had to, unfortunately, stop the trial. And one of the funding we even had to give back because we weren't able to recruit the required sites. But from the demographics with these small numbers we had recruited, we didn't find any difference. There was also no difference in any of the delivery room interventions. You can see that there was only half of them roughly intubated prior starting chest compression. And this is also related to the European approach where there's no intubation prior to starting chest compression. So there is this difference to the North American algorithm, and that was not defined in the protocol what to do because we didn't want to interfere with the guidelines. All babies were in 100% oxygen during resuscitation, and in the CCSI group, only 2 of the kids needed to be swapped to 3-to-1. So that means only 2 of these 11 had more than 5 minutes of CPR. And this is the primary outcome, was the time to ROSC. And I just want to highlight, it was 90 seconds of chest compression with CCSI versus 615, so over 10 minutes with 3-to-1. The p-value, and the only one on the right, that Cox p-value of 0.16 is important because it's the one when you adjust for the cluster. So it wasn't significant. The numbers are quite small. A change in 2 or 3 infants or 1 infant with a longer resuscitation time in the CCSI group would have changed a lot of these outcomes dramatically. However, what we had in the 3-to-1 group was in line with what you see from registry. Similar to survival, the survival was twice as much with CCSI, but again, the numbers are so small. Our 3-to-1 survival is slightly slower than what you see in some of the registries published, which was 64% in the one I have on this slide. There was also no difference in secondary outcomes, or we had pneumothorax and intraventricular hemorrhage as our safety outcomes, including mortality, and they were low in both arms, and certainly not increased in the CCSI group, which was always a fear from this technique from many people, as well as the DSMB. Now, given that we have done 2 studies now, 1 pilot, 1, let's say, phase 2 trial with a few more, we want to do another study. We have learned a lot. We've dealt with a lot of problems from ethics boards as well as insurance companies, which we now know how to overcome. So we really want to do another one, starting with applying for a grant in September next year. And if there's anyone interested in joining the trial and being a site, we would be extremely happy to have you on board. And with that, I'm saying thank you to everyone of the team members who either worked in the lab or were part of the resuscitation of that trial for all the work they've done, because it's not possible without such a large team. And I'm now happy to answer any question or have a good chat about all of that. Thank you.
May I request the moderators to kindly initiate the discussion.
Thank you, Professor George. That was a wonderful presentation. It's good to know that 2 studies have been done, the first a pilot trial and subsequently the RCT. But the outcomes, I think, because of a lot of reasons, I think we couldn't get the required sample in the second study. I think, but it's interesting to know that the results of the study, and I think a more ongoing research coming in this area will show more light regarding what is the right chest compression strategy to be used in neonates. I think
yes, for sure.
So there are some questions from our, from our participants. This is a question by Marwa Ahmad. If cardiac arrest has happened in the cardiac neonate with cyanotic or acyanotic heart disease, do we keep the compression breathing ratio 1:3:1, or do you use the? I think this is something I've been out of the scope of your lecture. So he's talking about maybe, yeah. So do you use the ALPS guideline of 15:2?
Yeah. So yeah, we didn't have that in the lecture, and it's really challenging to do, like, to try to test that in a lab to create a congenital heart disease model. But I know from our unit, because we have a surgical unit as well, we do pulse. So we do the pediatric advanced life support if there is a cardiac kit. That's the default we do. If you look at our CCSI technique, we have done 1-year-old piglets, like as well a correlation to a child. We have done 28-day-old. So we've done more studies and see if it also works in pediatrics. And so far, the studies we have done and published, CCSI is better than the pulse. But we haven't really tried it in cardiac kids. But in our unit, we do pulse 15:2 or the continuous once you have an airway.
In your own trial, I think you had excluded the babies with cardiac conditions diagnosed antenatally, sir.
Yeah. Yes, we did. And I must admit, we know, particularly at birth, we don't often do CPR on cardiac kids. I think it's something more once the babies are on the unit, maybe after surgery or so. But at birth, I haven't seen CPR in any of our cardiac kids. And we are a cardiac center, like we do a lot of them. But I haven't seen much CPR at birth in cardiac kids, to be honest.
Thank you, sir. I think, hope Dr. Marwa Ahmad has had his answer. So the second question is from Dr. Vimal Vincent. He has asked how long was the sustained inflation. I think I'm also interested in that. I think can you just describe your protocol of the sustained inflation group, sir? Can you, because I think you went through the protocol. Can you just describe it again? It will be useful for our delegates and panelists.
Yeah. So so we do. Well, let me best maybe if I put up the slide again or a slightly different slide. So let me just.
You can share your screen if you want again, sir.
Yep, I will. So yeah, here you can see that. Where is it now? So you provide continuous chest compression. Somehow the video doesn't work. Oh, no. So you provide continuous chest compression. Yeah. You occlude the T-piece at a pressure of 25 to 30 for 20 seconds. After those 20 seconds, you lift your finger off for 1 second. So at the end of the video, see it lifts off. You lift it off like you would do you lift it off up to 1 second. Yeah, you just lift it off for up to 1 second, like you would do a normal inflation. Yeah, and then you hold it again. And you do this again for 20 seconds. You lift it off again, and you do it another 20 seconds. And this is how you repeat it. So it's a constant of doing this for 20 seconds, lifting it off for a second, and doing it again for 20 seconds.
So how is this protocol different from the protocol in SAIL trial, sir?
The difference in SAIL was that, in SAIL, they also used up to 2 sustained inflations. Yeah, but they were doing it as the initial respiratory support. So we didn't do sustained inflation for respiratory support. We only did it when they started chest compression. So that's a major difference. And in SAIL, they used the 23 to 26 week infants, and we started at 28 weeks. Yeah. So we certainly have prevented any of these extreme small preterm babies which might have an issue with that sustained inflation by targeting on the older one. Yeah. Now, speaking to Canadians, Americans, Europeans to participate in this trial. Many would, for the next trial, would be happy to participate if we only do term babies. And most likely, we might just do term babies. 34 weeks was our average age in that trial. So maybe we do late preterm and term, but certainly don't go down to have any concerns that we run into any problems if we do that in extreme premature babies.
So any, idea why the SAIL trial actually had an increased mortality? I think what could be because they were also not able to clearly explain why the trial showed up an increased mortality in that particular group of premature infants. I think then it would be easier to convince your other sites to take up this trial.
Yes.
Are there any, trials, in this population which says that your sustained inflations are safer, at least when it is not meant for chest, as a chest compression tool, as a general thing, even as a respiratory support, is it safer?
It's a really interesting question because many trials have used sustained inflation and they did not find an increase in mortality. SAIL comes along and it found that increase in mortality. Now, if you put all in a meta-analysis, you will not find a difference in mortality. The European guidelines would still recommend up to 5 sustained inflations, but only for 3 seconds lengths. So even nowadays in Europe, despite SAIL, they will still do the shorter sustained inflations, as longer I times, which is standard. So I don't think it's the final word has said, but it's hard to do another like sustained inflation trial like SAIL did, just because of what SAIL found. But I think it might have been too early. There may be a few things we should have done before to figure out who needs it and how to do it. So we maybe have jumped the gun there a little bit. So, but that's what it is. But if you look at meta-analyses, and ILCO published one, and other people published one, there is no increased mortality with that approach if you put all the studies together.
Yeah, thank you, sir. I think there are more questions in the chat box. How do you prevent the side effects that the SAIL trial found? I think we have basically had the answers to that. That's what I was also trying to tease out. And there's one question from Supreet.
And just to add to that, like if you look at our, so if you look at our IVH rates, pneumothorax rates, mortality, there was no difference in IVH or pneumothorax with the 2 groups, and mortality was much lower with CCSI. So, we didn't see any of the side effects of SAIL.
Very interesting to know, sir. Dr. Supreet has congratulated you on this novel idea, research idea.
Thank you.
Yes, given all his best wishes for further recruitments. And Dr.
Thanks.
Marwa Ahmed is questioning whether is it applicable in neonates after placing an endotracheal tube that chest compression goes independently from breathing.
Yes, because in the end, what it does is like, if you do this with each chest compression, you push air out and then you get the air back in. So you're passive ventilating your child without needing to ventilate. So yes, it works after ETT. It works with mask ventilation. What we haven't investigated, but we're working on it, is losing a laryngeal airway or laryngeal mask, supraglottic airway, whatever you want to call it. So there hasn't been any studies, but I assume it will work as well. But this hasn't been studied with that.
Yeah. So there are a few more questions. May I invite our other moderator, Professor Dr. Sashi, to take over, sir, so that he can ask you the further questions.
Yeah. Thank you, sir. Good evening, sir.
Yep.
Yeah, here Southwick wants to know, when do we taper the FiO2 from 100% after chest compression, and how do we monitor the baby?
So if you have ROSC, you were in 100%. You have a pulse oximetry, I would just use the targets you use to taper off the FiO2. Yeah, so you basically use, if it's like, say, the baby's 5 minutes of age and you have ROSC and you're in 100% oxygen, then just use your reference range you use for any other baby to guide. If it's past 10 minutes and you have ROSC, then I would just use what you use for the unit policy, where you would like to stay within this range and titrate the oxygen accordingly.
I think the Suprit Khurana had a few more queries, sir. The first one has a team decided to check free radical damage caused by using 100% oxygen at the beginning rather than graded as per minutes of life. This is first question, sir.
Okay. I don't think anyone, I mean, there's some animal studies where they check free radical damages close to 100%. But again, this is really challenging to do in any of the newborns, because that's so rare and no one is most of the time there to do anything. But it's certainly, if you, and I know that from studies out of UC Davis or Buffalo Basatian, where they're investigating 100%, 50% or 21% oxygen, doing CPR and after CPR and titrating, that you should titrate and not leave the 100%, because then you just get a higher percentage of free radicals. So titrate them, the oxygen. I think that's the most important message.
Okay, sir. His second question is decision to end of life at 10 minutes versus 20 minutes after chest compressions.
So before 2020, I think ILCO recommendations were like, or most NRP, or I think the Europeans said you do 10 minutes of, and I think this was always something we maybe misinterpreted, because it said 10 minutes of effective CPR. And effective CPR would have meant a breathing tube, as well as a line in place to give epinephrine. And a lot of people would have, when the baby came out, would have done first 10 minutes and then would have stopped. So I think if you go back and say, 10 minutes of effective CPR, most likely you would have done 15 minutes at least, because you need to get those things done. And depending on your setting, you might take a few minutes longer or you're a bit faster. In 2020, they, I think it was led by Liz Foglia, they did a scoping review to see what's out there. And I think there's around 500 patients in that scoping review, which showed that 20 minutes, you should do 20 minutes of CPR, because there's still some survivors after 10 minutes with good outcomes. So the guidelines changed, or the recommendations changed to say 20 minutes of CPR should be done before you consider stopping.
Okay, sir. Thank you. The other question is, what is the role of 150 versus 180 chest compression rate, sir?
So,
is there any change?
In an animal study, it shows 150 might be the most effective with the cardiac output. So it hasn't been studied. Studies have done like 60 or 90 or 120 or 180, and none of them showed any difference. So 150 might be a sweet spot, but that needs to be studied. But also, I don't think you can do that with 3-to-1. I'm not sure if you can do that with any other technique, because you will get fatigue relatively quickly. But it might be something which we have to consider, because in adults or in pediatrics, they also do up to 120. They have a range. So maybe in the future, we say, look, you need a range of this to improve the outcome.
Any animal literature available on finger technique, sir?
Yes, there's this one study I presented by Bruckner, which is the only one in newborn, in animals. I think there's a couple, if you go to that scoping review by Ramachandran, in archives. I think there's a couple of studies in infants, not newborns, where they tried on the pediatric intensive care unit the 2 thumbs and the 2 fingers and looked at the waveforms. So there's also a couple of human studies, but not at birth. And one, and this one by Bruckner from a piglet model.
Another question from the same Supreet is there any difference in the rate of NDI at 6, 9, 12, 18 months for chest compression with a sustained inflation?
We don't know yet. We don't have all the data yet, but we're working on at least getting some of them.
Okay, thank you, sir. The other question from Dr. Supreet Khurana is the protocol being a bit complicated. Has the team worked on the generalizability by video recording trained teams?
So we did a good video for the team to be trained. So we had good training videos for each site to be trained. And I think certainly what you need is locally, when you join the study, that you locally need a reminder to the team, look, we're going to do this, we're doing this, because a lot of people are really trained in 3-to-1, so that you don't, dilute and start 3-to-1 in many of the babies if you're randomized to CCSI. One of our master students just did an implementation study on what happens if you would implement CCSI to the NICU, and we went to NICU, we went to surgical NICU, we went to Emerge, we went to PICU, and compared that to either 3-to-1 or Pulse, and everyone was saying it's so much easier because you don't need to think much about, you don't think about ventilation, you just occlude the T-piece, you hold it, and someone does CPR. Yeah, so there's no coordination needed, no counting 3-to-1, like 1 and 2 and 3 and breathe, nothing, you just do it. So everybody felt it's so much easier.
The other question is, are there any studies on cardiac output, ejection fraction, SVC flow on sustained inflation with a chest compression rate?
Yes, there's 3, all done by Bruckner. And so I think 1 or 2 are published in archives of disease in childhood, and 1 is published in children or Frontiers, maybe Frontiers, which examines, compare 60 to 90 with CCSI, 90 with 180 with CCSI, and all the different rates, 60, 90, 120, 150, 180 with CCSI.
Okay, sir. The other study is Dr. Supreet wants is there any study on FiO2 being delivered using SVO2 or cardiac monitor versus pulse oximetry?
I'm not aware there's any studies like this. So if Dr. Kuran has some studies, that would be great, because I'm not aware there's anybody has done anything with SVO2,
Yeah,
but it would be interesting to know.
Okay, sir. Thank you. From Rajesh, sir, we don't have to apply PPV during ESI, sustained inflation.
No, if you do like doing CCSI, you don't apply PPV because it's automatically with your chest compression.
Yeah, from Dorji, I would so grateful to organizer. If organizer could send me videos of NALS and MBLS with a detailed explanation. Dorji wanted the videos, sir, of the protocols of the NALS and MBLS.
I can share that with Manoj. Yeah, no, that's no problem.
We
Yes,
will share with all the delegates who request. We will share,
Yes,
share the thing. Yeah, we'll do that.
And Supreet, again, sir, should use of a SIB without PEEP valve be withheld till further data on trial available?
Well, I mean, it always depends. If you don't have nothing else than a self-inflating bag, then you can't really not use it. We use TPs in our hospital. We have self-inflating bags without PEEP. I think as a backup. So if the TPs fails, we would always use it. So I think for mask ventilation, if self-inflating bag is what you have without PEEP, then you should use it. There's no, I mean, you can't do anything else. So I would use it in that instance. Absolutely.
Okay. From Sharing Dorji, do we give defibrillators to newborn?
Well, if they need it, yes. I mean, it's extremely rare. But if you have a baby has ventricular fibrillation, you would have to give it. And I think, all of us have been trained that bradycardia systole is what the babies have, because we never used ECGs. And over the last 5 to 10 years, ECG was recommended by the guidelines. So we have seen pulseless electric activity. We have seen cases of ventricular fibrillation. So yes, you might need a defibrillator. Would you need to buy one?
Dr. Shashi, can I ask Professor Schmölzer, how much more time do you have? Because we have exhausted the time you allotted us. Can we go on for another 10 more minutes if it's okay with you?
Yeah. No problem at all.
Thank you.
Yes.
Please carry.
So
Can I ask that, sir?
But let me finish that with the defibrillator. Now, would I recommend that we buy one for the NICU? Well, I think some sites might have one on their code card or crash card on the unit. But if the delivery room is further away, like in our hospital, it's quite a bit away from our NICU. I don't think we need another one in the delivery room because you need to train the staff, and that might be a little bit more challenging. It might be easier to just call a code blue as we would do, and then the adults come or the pediatric people come with theirs, and then we can use that. So, but you might need defibrillation.
So how common, sir? Sir, how commonly we'll get an encountered asystole or pulseless electrical activity?
Well, it's hard to say. If I go to our Pictet model, we see 40-50% pulseless electric activity, so it's quite often. In newborns, there has been one case report in a preterm baby, a couple of case series with maybe 4 to 8 kids. So rare, but every time you speak to people, a lot of people have seen it, but they have not published it. Yeah, so I think it might be more common than we think. And I think, particularly since we have the ECG, people start to look at the ECG and say, oh, the heart rate is 80. And then they just provide positive pressure ventilation, but they have not realized that it's actually a pulseless electric activity. So there's no cardiac output because, we were trained to listen and palpate. Now we train, look at the monitor. Yeah, palpation, you're not good enough because you can't calculate right. So I think that people then stop doing those simple techniques and they might then miss them. So it might be more common than we think, but it's not reported.
Yes, sir. The other question from Dinesh, sustained inflation in this present study is similar to ARPV ventilation mode used in ARDS. Will it?
Yes. It's quite similar. It's like a BiPAP because the PEEP goes up and down. Yeah.
Yeah. Then from Deepa, sir, Deepa Bankar, would considering early administration of epinephrine help the time of ROSC?
Good question. There was an old study by, I think, Lina et al. A couple of decades ago, which showed it didn't help. And I think the group in Buffalo or UC Davis is working on it to examine that. But I don't know yet. I think if you have no circulation, I think you need chest compression. Early administration, there's the question how you're going to give it. We know ETT doesn't work well, so you need vascular access because there's no other way. So I think once you have vascular access, you can give it quickly. That might help, but you need vascular access, and that might be delayed depending on the size of your team.
Okay, sir. I'll ask Dr. Giridhar, sir, to take over for further discussion, sir. Thank you.
Yes, sir, sure. So we have some interesting question on epinephrine, sir. See, I mean, this return of spontaneous circulation. When there was a question from Dr. Aishwarya Venugopal asking whether how does the mortality rates? She was asking about morbidity, but I think can explain about morbidity and mortality rates. If your return of spontaneous circulation is achieved at different time points, 5 minutes, 8 minutes, because that was our primary outcome. I mean, what do you anticipate the mortality to change, sir, with this?
I think it's hard to just pinpoint down to the time, because I think there's many factors associated with this. Because I think you can have someone who maybe had 5 minutes of chest compression and then has a really bad outcome, and others might have 15 or 20 minutes and have a good outcome, because I think there's many factors associated with it before birth, like how long the hypoxia might have been. And I'm not aware of any studies who looked into that minute by minute. We have a database which we just got hand off, which has like births of the last 23 years collected throughout all of our province, and there's over 1 million births. So if there's a database like this in India, for example, it might be a good thing to analyze and see if there is what the outcomes are, because you will have a few thousand babies at least. But so far there's no study who did it minute by minute.
Yeah, I think the same person has asked, why are we changing from sustained inflation to conventional method after 5 minutes of chest compression if the ROC wasn't achieved? What?
That was the recommendation of the Data Safety Monitoring Committee. That was not what we wanted to do, but the Data Safety Monitoring Committee felt that it might not work, so need to switch.
And in your trial also, there was some, the sustained inflation group, there were some babies who had switched over to the 3:1 chest compression group. So two babies, sir. So why did that happen, in fact?
Because they were doing chest compression for more than 5 minutes.
Okay.
Like how it was designed in the protocol. So yeah.
Yes.
But in the new protocol, this will not be in. Like in the new protocol, we wouldn't do that.
Okay, fine. So I think Dr. Supreet Khurana is questioning whether there could be an Hawthorne effect, the bias which could creep in. So is a video recording of the whole trial rather than simple crossover would help to give a less biased outcome in terms of performance bias?
Yep. Yeah, absolutely could be. I mean, yes, we could try video record the whole trial, but I don't think not everybody has video recording. Like if I look at our site, we have 2 rooms where we can do video recording, but most of the time they're preterm babies delivered. The term babies that deliver in the normal delivery suites, and not necessarily we are able to video record. So this will always be a problem. But I think if the team is well trained, then they certainly will do the right technique as with any other trial. But yes, it's a fair point that there might have been bias because of that. Absolutely.
So another question is from again Dr. Supreet Khurana is asking whether palpation of the cord is it inferior to auscultation of heart rate?
Yes, there was this study made 20 years ago or so who showed that we over or underestimating the heart rate when we are measuring it by the by palpation. Now, I think one of the problems with many of these studies was that they were using healthy babies, mostly in the NICU, and they were assessing normal heart rates. Yeah, and I totally agree. Like if you have a heart rate of 140 and you palpate it, and then you palpate for 6 seconds and multiply that by 10, you might be wrong. Happens. But if the heart rate is 40, I think you might be more likely to get it right. The fear, I think, sometimes is, and that might be the same with auscultation. You know, you listen, you don't hear anything. You ask your colleague, "Can you listen?" The next one listens, so the next one palpates, can't feel it, and the next one. So I think there's often sometimes a delay which we don't want, because we don't want to delay the start. But the studies out there showed that auscultation is better than palpation, but it's worse than any of the monitoring.
So I think we are more or less completing the list of questions. The last question is by sharing Dorji. I think in babies who have other anomalies like your meningomyelus heals and gastroschisis, basically open defects. I mean, how will be any modification of the protocol will be required in these sort of babies, sir, especially your protocol which you have told us?
Well, I mean, we haven't really included any in any of our studies because these are generally excluded. But I think, given that these birth defects are more common in other places than what we will see, I think for potential future trials, it would be good to include them because you want to get an answer if in any of these other diagnoses it might work as well. So I think for designing the next trial, we will be open to include any of them just to hopefully maybe get an answer, because a lot of these congenital abnormalities are always excluded for any trial, and you then left with doing something where you don't know what to do, and you try to do something which works maybe in a healthy baby or in a preterm baby, but you have a condition which hasn't been studied. So
yeah, and that completes the list of questions, sir. I think sorry, I just left one more.
Right. Okay, sounds good.
Yeah, I mean, so I think we're almost short of time. In a team of two, can it be that simultaneously assessed heart rate or UVC palpation? I think it's a continuation of the same question. UVC palpation as against
I think
auscultation for thing.
I think if you have the stethoscope in, you hold it down and measure. I think you can do that. I mean, I think both can do it, or if one does it, I think if you can split your brain that you can listen and count and feel and count. I don't know if I can do that, but if you can do that, yeah, for sure. And if two people can do that, yeah, that works as well. Absolutely.
Okay, yeah. So that completes the list of questions, sir. I think it was wonderful having you here in our webinar. I think we from NNF and the next team are very happy that you could join us. I think we sincerely hope that the study evolves so that towards its logical conclusion, more centers volunteer to participate, and we have the final definitive answer, sir. So any further comments from our other moderator, Professor Dr. Sasi?
I think, sir, it is a wonderful study, sir. I think it needs some time for in India to go follow this, because we have to convince and to see further some more studies. Otherwise, we'll see, sir. We'll see into it.
So thank you, sir. And over to Professor Dr. Manoj.
Thank you, Dr. Giridhar and Dr. Shashi, for a wonderful challenging moderation of the questions. Professor Georg Schmölzer, it was very interesting to hear the challenges you had undergone and the lessons that we all learned from when you have a novel idea that could benefit the newborns and the society at large. What are the real challenges which are not purely academic as well? Very interesting insights also you are given. And then as we always say, these we need to learn to be smart to get to live with it. It is so nice of you to spare time today early in the morning in Canada, and we thoroughly enjoyed this lecture. This is again one of those lectures where with a lot of eye openers. So thank you so much, sir, for being with us. We also hope to have you in person in the coming year and thereafter for the further deliberations on this topic and the other topics as well. Thank you, sir.
Thank you for having me. Yes, and looking forward.
Thank you.
To coming in, as well as maybe having some sites in future trial.
Thank you, sir. Thank you so much. We will be in touch with you regarding that. And before
Yes,
we close,
and-
the final word of gratitude to all the respected attendees who have been with us for the last 3.5 years in all these webinars. Now, it has been a wonderful journey, learning so many new things together. I would again invite you for the next session coming up next month, 16 November, again on another interesting area. Some of the newer insights into the concept of iron supplementation in neonates. Of course, the person who has done a lot of work in this, Professor Rakhavendra Rao from University of Minnesota, will be there with us on that day. So I invite all of you to join us on that day. Until then, have a good time. Thank you. Thank you, sir.
Thank you, everyone.
Bye-bye, everyone. Have a good evening.
Thank you.
Thank you, sir.
Bye.